Hello. Today I'm going to discuss the seronegative spondyloarthropathies, specifically Ankylosing Spondylitis and Reactive Arthritis, or what was formerly known as Reiter syndrome. I'll discuss psoriatic arthritis in a different talk. In the past, I stated that these lectures can stand alone. However, as we move forward into the lecture series, I find that it is important to understand some of the stuff we've talked about before. So I would encourage you to review the introduction talk. We talked a little bit about the anatomy of the joint, and also the talk on rheumatoid arthritis and the treatment of rheumatoid arthritis, as those are referred to in this talk. Thank you again for listening to my lectures. As we discussed before, these were originally intended for sophomore medical students, but I wanted to put them out there in case anybody else had any interest. I'll talk again when we're done.
Today we're going to talk about the seronegative spondyloarthropathies. These are a group of rheumatologic conditions characterized by their lack of rheumatoid factor, and thus they're seronegative, and by inflammation of the bony insertions of the tendons and fascia, or what we call an enthesiopathy. This includes conditions such as ankylosing spondylitis, Reiter syndrome, or what we now call reactive arthritis, psoriatic arthritis, enteropathic arthritis or enteropathic spondylitis, and those are conditions associated with inflammatory bowel disease like Crohn's disease and ulcerative colitis, Behçet's, Whipple's disease, and etc. And again, as I mentioned, they're characterized by absence of rheumatoid factor and other antibodies. So this is the definition, as I said again, a group of rheumatic diseases characterized by lack of rheumatoid factor and by inflammation of the bony insertions of the tendons and fascia, or enthesiopathy. They're clinically distinct from rheumatoid arthritis in that they have different articular manifestations, and in particular they have different extra-articular manifestations. Their response to treatment is different and their prognosis is different. Now, when we discussed what causes the other rheumatologic diseases, we mentioned that there's a feeling that there's a genetic basis and there's something in the environment that kicks it off. With respect to the seronegative spondyloarthropathies, it's more clear what is going on. The genetic factors, this is just showing the gene chromosome 6 and the HLA transplantation antigens, or what we call major histocompatibility complex associated with that. There's the D antigens, which we've discussed also when we talked about rheumatoid arthritis, or the type 2 antigens, and then there's the type 1 antigens A, B, and C, which are involved in the seronegative spondyloarthropathies. Now, the type 1 antigens are involved on all cells. The type 1 antigens are involved in all cells, and they're necessarily to be presented to the cytotoxic T cell to initiate a lethal hit. What has been found in the seronegative spondyloarthropathies is that there is a close association, although not 100%, with the type 1 antigen HLA-B27. And there's much data to support that. First, there's what we call epidemiologic evidence, and that is, what do we see when we look at patients that have these diseases? 20% of patients that have the HLA-B27 will get a spondyloarthropathy, one of the seronegative spondyloarthropathies. Of our patients with ankylosing spondylitis, 90% will have the HLA-B27. And of the Caucasian population, 8% of Caucasians have it. So you can see that there's a definite difference between the number of people that get the disease that have the HLA-B27 antigen versus the normal population, because 92% of the normal population does not have the antigen. And we find that ankylosing spondylitis runs in families. Now, another compelling study to show the effect of HLA-B27 was the transgenic mouse, and this is a study done by Hammer and colleagues. Basically what they did was they took a mouse and they inserted an HLA-B27 gene into an embryo and watched to see what happened to the offspring, to the embryo that had the HLA-B27 gene. And what they found, interestingly, is that these mice developed many of the features of a seronegative spondyloarthropathy, and specifically they had a peripheral arthritis, they had spinal lesions, and this shows the peripheral arthritis here. Spinal lesions, this is actually the tail of the mouse, but it's a continuation of the spine. You can see that they're swelling there. They developed dactylitis, which we're going to talk about further. They had inflammatory bowel disease, and they would have inflammation of the testes and skin lesion. Now, this slide was taken from a study that showed the HLA-B27 misfolding is associated with inflammatory bowel disease in association with a human beta-2 microglobulin gene error. And that seems to be the inflammatory bowel disease. This does not seem to be as important in the inflammatory arthritis or spondylitis associated. The gut flora affected it, and we're going to talk about that in humans in a minute. In a way, this is like using Cook's postulates in order to prove the genetic cause of disease. So we have three pieces of evidence that show the strong association with HLA-B27, and there's some postulates as to why this might occur. The major histocompatibility antigen may act as receptors for the pathogens that can cause disease, or an antigen binding groove on only certain HLA can accept the process antigenic fragment. In other words, if even if the antigen's present, if one doesn't have the antigen binding groove, it doesn't cause disease. The T cell can only recognize the antigen when presented with the correct HLA-B27. Of course, that's always true. The T cell can only recognize it if it's presented with an HLA or a major histocompatibility complex. And lastly, there could be a molecular mimicry. In other words, the antigen peptide looks similar to the HLA-B27. So we've shown that there's a genetic cause. There is then evidence, clinical evidence, to suggest that there's something in the environment that kicks it off. And in particular, the classic description of what was called Reiter syndrome, which was a triad of urethritis, conjunctivitis, and arthritis, can follow an enteric or, venereal infection. And these are a list of the bacteria that have been associated with reactive arthritis or Reiter syndrome. You'll see many of these are enteric, some of these are venereal, and actually there's certain acne bacteria that can be associated with the reactive arthritis. Now, what's the pathologic anatomy? What do we see? Again, primarily the site is at the enthesis, and there's inflammation of the insertion of tendons and ligaments into the capsules or bone. So it's different than the synovium that we see in rheumatoid arthritis. This is an example of a ankylosing spondylitis spine. This is the vertebrae, and this is the annulus fibrosus. Normally this is just a thick tendon band, but you can see in this that there's a lot of calcium. So there's calcium in the annulus fibrosus. This is just you can see the picture here. The x-ray where you can see the calcium. Another example is a sacroiliac joint, and what we see here is we actually see fusion of the sacroiliac joint. One cannot even see the sacroiliac joint because of calcification and obliteration of the joint. So how does this progress then to disease? How do we think the inciting factor leads to disease? And this is just the theory of how it occurs. There's low-grade inflammation of the bowel, which allows absorption of the microorganism. The microorganism then is taken into the antigen-presenting cells and presented to the T cell. This is leaked with the HLA, and the HLA, of course, is on all the cell surfaces. When that interacts with the T cell receptor, that can lead to disease and arthritis. So that's sort of a theory of how we think this occurs. Now, how does this disease present? What do we see? And these are some of the common features of the seronegative spondyloarthropathies. Number one, there's a spinal predilection, particular with reactive arthritis and ankylosing spondylitis. There can be sacroiliitis and spondylitis. Generally, it's oligoarticular, and that means is that there's few joints involved. There's not a lot of joints involved. It's not like rheumatoid. There's inflammation at the bony insertions of the tendon and fascia, what we call an enthesopathy. There are extraarticular inflammation, and this is actually what characterizes these diseases a lot, and we'll talk about that as we go through the pictures and slides. Generally, it's young adult, usually men, and one can see how this is different than rheumatoid arthritis and lupus, which is more often women. And again, this is associated with an HLA-B27. So we first want to talk about the seronegative spondyloarthropathy called ankylosing spondylitis. And basically, it involves primarily the axial spine, and it's associated with pain and stiffness, leading to fusion or ankylosis. Spondylitis typically means inflammation of the joints of the vertebrae, so ankylosing spondylitis means fusion and inflammation of the joints of the vertebrae. This is the prototypic spondyloarthropathy and the one with which the others are compared. Now, epidemiologically, as we mentioned, it tends to be young men more often than women, and it tends to be young adult. And my experience is this generally presents in the teens and 20s. It may not be diagnosed till later, and I've had patients that presented with findings of ankylosing spondylitis much later than in life, usually sometimes in their 40s, 50s, or 60s. But when questioned, one can find history of symptoms and the problems dating back into the teens and 20s. And again, this tends to hit Caucasians more than other ethnic populations. Symptomatically, they have low back pain. This is generalized and insidious, and it's an inflammatory back pain, and we'll talk about that in a minute. There's morning stiffness of the low back, such as we discussed morning stiffness of the peripheral joints in rheumatoid arthritis. We see morning stiffness of the low back, and it can be associated with constitutional manifestations such as weight loss, low-grade fever, etc. Now, this is from the ASAS, which is Assessment of Spondyloarthritis International Society, and they have a nice set of slides on the internet of these things. This talks about inflammatory back pain and the things that we look for in order to classify that. Number one, it's generally young, less than 40. It's insidious in onset, so it's not like they can point to a thing that set it off, like lifting or something. It tends to improve with exercise, and this is different than like osteoarthritis, low back pain. There's no improvement with rest, and again, different than osteoarthritis, low back pain, and there's pain at night, and it improves when one gets up. So in order to classify as inflammatory back pain, one needs to have at least 4 of the 5 parameters. Now I'm going to talk a little bit about what we see clinically in ankylosing spondylitis. In this picture, one sees this gentleman's reaching for the floor. He cannot reach the floor. That's as close as he can get. And if you look at his spine, you'll see that there's the normal dorsal kyphosis, and then he doesn't lose his lumbar lordosis as he reaches for the floor. And this is different than normal, and this is just an example of normal. You can see again the normal dorsal kyphosis with lumbar lordosis, and I outline that here. And as one reaches for the floor, one loses the lumbar lordosis, and the spine almost gets this C shape. You can see that there's this C shape here, and that's normal. That's what happens in normal function. What we see in this gentleman is as he reaches for the floor, there is not loss of that lumbar lordosis, and so you still see the flattening of the spine there. This is a progressive set of pictures of a patient with ankylosing spondylitis, and as you see, as time progresses, he becomes more hunched over. There's actually no movement of the spine. He's having to use his hips for motion, and there's probably some hip involvement in this. This is what we saw previously when we looked at the Pathologic Anatomy. This is an X-ray, and this is what we refer to as a bamboo spine. And again, what you see is you see the normal vertebrae here, you see the annulus fibrosus, and in normal X-ray that is not seen, and so you just sort of see the vertebrae. In normal X-rays, you see the vertebrae stacked on each other with a gap in between. Here one sees the calcium of the annulus fibrosus. This is an example of the sacroiliac joint, and what one sees here is essentially you can sort of see it's becoming obliterated. You can sort of see the periarticular sclerosis here, and again the sacroiliac joint is becoming obliterated. Interestingly, you can see that his spine is still normal, and we contrast that to the previous slide. You can see the stacking of the vertebrae, and you don't see the annulus fibrosus. We've seen this slide already. This just shows what's happening to the sacroiliac joint, and whereas there should be a gap between the sacrum and the ilium here, we don't see that. And again, we can see on X-ray that that's obliterated. Now, early in the course of the disease, the sacroiliac joint can be maintained, but one with MRI can begin to see bone marrow edema around the joint. And this was actually an early presentation, and when we look at the classification criteria by the ASAS, we'll see that we can use this as a classification criteria to help us diagnose the disease earlier. Now, clinically, when we examine the patient, how do we measure the spine? How do I measure the spine? And one thing that's helpful is what's called a Schober test. Basically, on the back, I follow along the crest of the iliac crest down till the thumb will fall into a dimple, and this is about at the level of L5, S1. So I draw a little line there. I measure up 10 centimeters and down 5 centimeters, which is about 15 centimeters. Then I have the patient reach for the floor, such as we saw the gentleman doing in the previous slide. I then remeasure this distance. Normally this should distract to greater than 20 centimeters. So if it doesn't, that gives you a clue that there may be some loss of motion of the spine. Now, it's not diagnostic of ankylosing spondylitis. One can see it in osteoarthritis, so you need to look at the other clinical factors. But it is helpful in making the diagnosis, and it's also helpful in following the disease. Other things that I look for is chest expansion, and we measure the chest at the level of the nipple in a man and just under the breast in a woman. Have them blow out all of their air and then inhale. They should be able to expand their chest 5 centimeters. Now, there is some problem in this measurement in women because the chest expansion actually increases as one goes down the chest, and obviously if you're measuring under the breast, you might not be quite at the right level, but it's a helpful measure. The other thing that I like, and it's not listed in textbooks, is what I call the occiput wall distance. Basically, I have the patient stand with their back to the wall, the heels to the wall, hips to the wall, and see how close they can get the back of their head or the occiput to the wall, and I measure that. That's limited in ankylosing spondylitis, and generally it's greater than 0. You can measure a distance. There's a large joint extra spinal involvement in ankylosing spondylitis. As many as 35% of patients with ankylosing spondylitis can have extra spinal involvement. Typically, it's more often large joints, although any joints can be involved. More often it's in the hip, possibly the shoulders, etc. They also can have enteropathies, and basically, as we discussed earlier, that's inflammation of insertions of tendons or ligaments. In these two slides, one can see an enteropathy of the insertion of the Achilles tendon. There's an erosion, or they can have inflammation insertions into the of the plantar fascia to the calcaneus. This is just sort of obliterated with edema down here, and you can't see that. They can have extra-articular involvement. Again, these are systemic diseases. Up to 80% of patients can have inflammation of the prostate or prostatitis. Eye involvement can occur in up to 25%, and they can have either an iritis or conjunctivitis. This actually is an example of both. One can see a lot of redness and injected the conjunctiva. There's actually been a lot of inflammation. This is the iris, and one can see that the iris is sort of stuck down to the lens. These are called synechii, and there does appear to be little particulates in the anterior chamber, which is most likely white blood cells, and there's been inflammation here. Pulmonary or lung disease can occur as a late manifestation, and they can get upper lobe fibrosis, which we see here. You can see that there's increased density in this left upper lobe and scarring. They can have cardiovascular involvement, in particular inflammation of the great vessels. This is a cross section of an aorta with what we call inflammation or aortitis. There can be other manifestations of inflammation, including amyloid, which is an occasional complication. Neurologic involvement can occur, but this is more at the level of the cauda equina, probably related to the inflammation and fusion of the spine, but this can cause leg and buttock pain. So how do we make the diagnosis of ankylosing spondylitis? This is taken from the clinical criteria for ankylosing spondylitis from 1966, and again, this is probably more of a classification criteria for studies. We've talked in our previous lectures about how classification criteria are used more for the purposes of study to agree everybody is in the study has the disease, but I think these are again useful in helping us to identify ankylosing spondylitis. Basically, clinically, one looks for limitation of motion of the spine in all three planes, or a history of pain in the dorsal lumbar junction, or limitation of chest expansion, and then looks at x-rays. And we're going to look at the x-ray classification criteria, but grade 3 or 4 means certain sacroiliitis on x-ray. And if one has sacroiliitis on x-ray with at least one clinical criteria, one can classify as ankylosing spondylitis. Now, this obviously is later in the course of the disease, and we'll talk about our more recent classification criteria because this would limit you to people that have already had sacroiliac changes on x-ray. Definite is described as bilateral or unilateral with clinical criteria 1, so if they have unilateral sacroiliitis and loss of motion of the spine, or with both 2 and 3 with grade 3 or 4 changes unilaterally, one can classify, and probable is if you just see sacroiliitis with no clinical criteria. Now, these are the x-ray changes used in the New York classification. Ankylosis is pretty easy to recognize on x-ray. We've seen x-rays of that already where the sacroiliac joint is obliterated. Moderate is pretty easy to recognize. The joint's pretty well blurred. Minimal and suspicious are pretty subjective. So if you definitely see it on x-ray and there's loss of motion of the spine, one can classify. Now, the ASAS classification criterion. We talked about ASAS as Assessment of Spondylitis International Society. Their criteria actually doesn't use the word ankylosing spondylitis. They classify this as axial spondyloarthritis, and we're going to see how that differs from peripheral spondyloarthritis when we talk about other conditions. They do require the patient to have at least 3 months of back pain, so it's not something that just started, and to be less than 45 years old. If they have sacroiliitis on imaging, and imaging can be either x-ray, which we've talked about, that was definite radiographic sacroiliitis by the modified New York criteria, or if they have clues of inflammation on MRI, and we looked at the edema plus one feature, they would classify, and they list inflammatory back pain, which we discussed, peripheral arthritis, which we discussed, enthesitis, uveitis, we've talked about the eye and how there can be inflammation in the eye, dactylitis we'll discuss later, psoriasis we'll discuss later, inflammatory bowel disease such as Crohn's disease or ulcerative colitis, or a response to non-steroidal anti-inflammatory drugs, a family history of spondyloarthritis, HLA-B27, or an elevated C-reactive protein. If they have any of these things plus an imaging feature, they would classify. Or if they just have the HLA-B27 plus 2 other of these down here, they would classify as having an axial spondyloarthritis, and that we can equate to ankylosing spondylitis. In this slide, we see how the ASAS defines a positive MRI for sacroiliac joint involvement. And again, what they're showing or what they want to see is the presence of definite subchondral bone marrow edema in order to make that classification. Now, what looks like ankylosing spondylitis? What's in our differential diagnosis? Number one, mechanical low back pain. And again, this is very common and frequently in the differential. Probably things that are different than ankylosing spondylitis. Number one is usually one can point to the onset. It's not insidious. Number two, they do not typically have what we call inflammatory back pain, and specifically that's back pain that's worse in the morning, gets better with exercise or activity. Osteoarthritis can have low back pain, and when one measures the spine there can be loss of motion, but this tends to hit a different age population. Osteitis condensans ilii. This is an X-ray finding typically seen more often in young women of childbearing age, and what one sees on X-ray is that there can be sclerosis around the sacroiliac joint, and too frequently is called sacroiliitis by the radiologist. So one needs to be aware of this when one's going to classify or make the diagnosis of ankylosing spondylitis. Reactive arthritis or Reiter syndrome, by the current ASAS definition, it's probably not important that we differentiate reactive arthritis from ankylosing spondylitis. Likewise, psoriatic arthritis, when we look at the ASA classification, psoriatic arthritis can present with spondyloarthritis, inflammation of the spine, and psoriasis. And so again, it's probably not too important that we make the difference in the classification because they're all part of the same spectrum of diseases. And then lastly, I listed fibromyalgia. Fibromyalgia can cause low back pain, but historically it's different. Now there's a lot of other things one needs to think about, but these are the top type of conditions. Special studies that I do in order to work this up. Usually I will do a pelvic x-ray. That's the first look I get at the sacroiliac joint. One can get dedicated sacroiliac joint films, and specifically a pelvic x-ray looks straight at the pelvis like this, whereas a dedicated sacroiliac joint film will come in at an angle in order to look right down the sacroiliac joint. An MRI can be helpful if there's not sufficient criteria by x-ray. Classically, I did not favor the HLA-B27. However, as one looks at the current classification criteria by the ASAS, they include HLA-B27 as a classification criteria, so that can be helpful in making the diagnosis, provided that you're looking at inflammatory back pain and not something else, because an HLA-B27 with low back pain doesn't necessarily mean that one has ankylosing spondylitis or axial seronegative spondyloarthropathy if the pain is not inflammatory. Treatment. So one thing that I strongly favor is flexibility and stretching in these patients, and specifically I ask them to go through the range of motion of their joints of their back at least once a day, reaching for the floor, reaching for the ceiling. I also ask them actually to lay on the floor and stretch out and try to get the back as straight as possible. If fusion is going to occur, I would rather they fuse in a more upright position than bent over as the gentleman that we saw. Non-steroidal anti-inflammatory drugs, and in particular things like indomethacin, which is one of the older nonsteroidals, can be very helpful, and indeed for many of our patients this is sufficient therapy. Not all of them, and we'll talk about what other options we have. Sulfasalazine has been shown to be helpful for the peripheral arthritis associated with ankylosing spondylitis, but does not help the spine. And then more recently we have the options of the biologics, the TNF-alpha blockers and the anti-IL-17 blockers. The TNF blockers being things like etanercept, infliximab, adalimumab, golimumab, and sitolizumab. and the IL-17 blockers, things such as secukinumab and ixekizumab, can be of help. And lastly, the Janus kinase inhibitors. Now, we've discussed these last 3 or 4 medicines in the talk on rheumatoid arthritis, and I would refer to that if there's any questions about these medicines. With respect to follow-up of these patients, I do serial measurements of the spine and chest, and we talked about those things like Schober testing, occiput wall distance, chest expansion. The medicines that are used determine a lot of the follow-up. If there's non-steroidal anti-inflammatory drugs, I've watched those and follow for their side effects. And likewise, if there's the use of any of the biologics or the JAK inhibitors, I'll watch for side effects of those. I'll monitor for complications of the disease, and then specifically we watch the lung for fibrosis, the aorta for incompetency, which would imply there might be an aortitis. Generally, the prognosis is pretty good for pain and function, but generally, at least with the older treatments, there was a loss of mobility. I will say that I had a lot of years experience treating with the biologics, but you have to understand we watch these diseases for many, many years before we know to what degree they have loss of motion. As I mentioned, some patients have little loss of function and don't even recognize that they have disease. I've had patients that come in, like I say, in their 40s or 50s for some other thing such as gout, and I recognize that they've lost motion of their spine, examine them, and they've lost sometimes total motion of the spine, get an x-ray and their sacroiliac joint is obliterated, thus they meet the criteria, but they don't remember really having a lot of problems, and they can complete their working career. Now, the next seronegative spondyloarthropathy I want to talk about is reactive arthritis or Reiter syndrome. More recent classification would call this seronegative spondyloarthropathy axial type, and we'll talk about that. Typically, they are classically described as having a triad of urethritis, conjunctivitis, and arthritis. The reason this is attached to the name Reiter was he described this in World War I in the trenches of Germany, whereas several weeks after at that time a diarrheal illness, although it can occur following venereal disease or sexual exposure, patients will develop the urethritis. It can be manifested as burning with urination or dysuria, or possibly a discharge, a mucopurulent discharge. Men may sometimes have prostatitis, women may sometimes have cervicitis. The conjunctivitis or inflammation of the eye can follow shortly thereafter. They can sometimes have iritis with pain in the eyes, redness, and photophobia. And then the arthritis can occur last. Generally it's pauciarticular, which means few joints and large joints in the lower extremity. There can be diffuse swelling of the joints, such as the toes, causing sausage digits or dactylitis. So that's sort of the classic description. We're going to go through some pictures. As I mentioned, the classic name of this was Reiter syndrome. However, Hans Reiter was a Nazi. Actually, he even was involved in World War II, involved in human experimentation. So we are trying to get away from that name, although it's still used a lot. And so again, the name reactive arthritis or seronegative spondyloarthropathy peripheral type is used more often. I tend to prefer the latter name because I think it recognizes that these are sort of a group of conditions that can have a lot of overlap, and I guess you would call me a lumper rather than a splitter. I'd rather put them all together under one title than try to differentiate the different titles. So I just went through a shopping list of some of the different manifestations of reactive arthritis, and I've listed them again here. We will go through and look at pictures of a lot of these things to try to help you remember what they are. So this is just an example of the large joint arthritis that can occur with the reactive arthritis. And again, you can see that there's been evidence that the patient has had this joint aspirated, but you can see that there's swelling of this joint with respect to this joint. And I would submit there's probably fluid in both the joints, and again, it looks like both the joints have been aspirated. This is what we call a sausage digit or dactylitis. Actually, this is probably more in psoriatic arthritis because they're pointing out the psoriatic plaques. But what one can see is that there's involvement of all the joints of a finger, and it can give the finger the look of a sausage, or what we would call a sausage digit. There can be inflammation of the insertion of tendons into bone, or what we would call enthesopathy. This is an inflammation of the Achilles into the heel, and there's swelling here. The name lover's heel came from the fact that this can be associated or set off from a venereal disease. Again, this is an example of that. Again, what one sees here is that the insertion of plantar fascia into the calcaneus, there's a little erosion of the spur, implying an inflammation or an enthesitis. They can have sacroiliitis, just as we discussed in ankylosing spondylitis or axial spondyloarthropathy, and what one sees here is sort of haziness or blurring around the joint. So there's definitely sacroiliitis on this would be the patient's right side. We're looking at this anatomically like we're looking at an x-ray on the right here, whereas it's not on the left. So epidemiologically, this tends to be, as I mentioned, young adults more often. Again, like this ankylosing spondylitis, the male to female predominance is much greater. It tends to affect men in a much greater number than it affects women, on the order of 9-1. We talked about how infections can set off arthritis when we talked about the pathophysiology of the disease. There's lots of different infections that can, and these are some of them. Enteric infections, which would call epidemic Reiter syndrome, post-venereal or endemic, and that was things such as chlamydia, mycoplasma. There's a definite HLA-B27 association. About 80% of patients have it, and HLA-B27 individuals have a 20% risk of getting a reactive arthritis. There can be urogenital involvement, urethritis, inflammation of the urethra, cervicitis, inflammation of the cervix, or prostatitis. And so in these patients, it's important to, number one, get a urine to see if there's urethritis, see if there's white blood cells in the urine. Patients should probably have a pelvic exam or a prostate exam. This is an example of the conjunctivitis that can occur. This was a gentleman that had the knees drained we saw previously, and you can see that there's edema of the lids. He has some redness of the conjunctiva. This is an example again of conjunctivitis, and one can see the associated arthritis. This is keratoderma blennorrhagica, and this is a skin condition. It looks a lot like psoriasis, tends to occur on the palms and soles. You can see sort of this little cobblestone appearance down here. This is succinate balanitis on the head of the glans penis, and what one sees here is little ulcerations. There can be a nail dystrophy, and we'll talk about that again when we talk about psoriatic arthritis, but one can see a nail dystrophy with separation of the nail from the nail bed here and up here. These are some of the late manifestations of reactive arthritis, including sacroiliitis. So we don't tend to see this as early as we do in like ankylosing spondylitis. They can have a progressive iridocyclitis, which is inflammation of the iris and the ciliary body of the eye, which can affect vision. There can be cardiac abnormalities such as palpitations or heart murmurs or rubs or regurgitation. We talked again about how the aorta can be involved in ankylosing spondylitis. There can be central nervous system involvement, and this can include things such as peripheral neuropathies, transient hemiplegia, and cranial nerve lesions. And then they can have lung involvement such as pleuritis, inflammation of the lining of the lung, or pulmonary infiltrates. So this is how we classify the disease. And again, this is the classic classification criteria. Basically, we look for an asymmetric inflammatory arthritis. And again, I use the word inflammatory. We'll differentiate that from osteoarthritis. Plus one of the extra articular manifestations, including urethritis or cervicitis, or something that sets it off, such as dysentery or inflammatory eye disease. And we talked about the mucocutaneous disease, such as the balanitis, oral ulcers, or the keratoderma blennorrhagica. And again, things that are in the exclusion criteria are basically things we might lump with the present criteria, including ankylosing spondylitis and psoriatic arthritis. Now, the current ASAS classification just classifies it as a peripheral spondyloarthritis, and again, they're looking for clues of either an arthritis or enthesitis or dactylitis plus one other feature. Now, if it's arthritis, the one other feature shouldn't be arthritis, and that's listed in the two other features, but they're looking for one other feature such as uveitis, psoriasis, Crohn's disease, or ulcerative colitis, an infection that could have set it off, and we talked about the infections, the association with the HLA-B27 sacroiliitis on imaging. If they have one of these and none of these features, then we look for another one of these features. So if they have an arthritis and none of these features, but there's an enthesitis, we might classify likewise enthesitis with an arthritis, etc., history of inflammatory back pain, and a family history of an inflammatory spondyloarthropathy. The differential diagnosis, again, the other spondyloarthropathies, but again, I don't know if the differentiation between one versus the other is all that important. There's a long differential diagnosis for monoarthritis, and we'll discuss that somewhat when we get into our discussion of septic arthritis and joint aspiration. My initial talk, Introduction to Rheumatology talk, and Introduction to the course, I went through a flow sheet of how to approach diseases of the joints. Other sexually transmitted diseases such as disseminated gonococcal infection can be associated with an arthritis, and other conditions. Besets, of course, that's more of a seronegative spondyloarthropathy, but infectious conditions that involve just a few joints, such as parvovirus or Lyme disease, are also included in the differential diagnosis. Now, the special studies that I do in evaluating the peripheral spondyloarthropathies or reactive arthritis. Number one, as I mentioned, typically it's associated with osteoarthritis. So whenever one sees osteoarthritis or monoarthritis, one should aspirate the joint to see if it's inflammatory, to see if it's infected, and I have a separate discussion of that on a future lecture. Given that this can be associated with venereal disease cultures for the genital cultures, the cervix or the urethra, anal cultures, and oral cultures should be done looking for clues of sexually transmitted disease. X-rays of the sacroiliac joint should be done. Either one can get a pelvis film or a dedicated SI film. And if that's negative and one's suspicious, an MRI of the sacroiliac joint. I find the HLA-B27 can be helpful in this condition, and so I will check that. And then I usually will get the usual studies looking for clues of systemic disease, including a complete blood count, SED rate, urinalysis. Given that this could be in the differential diagnosis or seropositive inflammatory arthritis such as rheumatoid or lupus, I'll get an ANA and a rheumatoid factor. And again, I would expect them to be negative. It is indeed a seronegative spondyloarthropathy. With respect to therapy of this, I find that non-steroidal anti-inflammatory drugs can be very helpful. A lot of times the reactive arthritis conditions have a short course, and if we can control the symptoms with non-steroidal anti-inflammatory drugs and judicious injection of the joints, a lot of times that's all we have to do. Now, if they're not responding to that, then disease-modifying anti-rheumatic drugs can be used. And usually I use things such as sulfasalazine or azolvedine, methotrexate, azathioprine, the same types of things that I would use in the treatment of rheumatoid arthritis. And again, I would have you refer to that talk if you want a discussion about the different medicines. If there is an enteric or venereal infection that has set it off, I'll treat that. So antibiotics can be used in order to control the underlying infection, although they probably don't really affect the course of the inflammatory arthritis once it occurs. With respect to follow-up, generally I find that a lot of these are self-limited and usually just follow them until they resolve, but sometimes they require long-term follow-up. So that concludes my discussion of the reactive arthritis. I would like to talk about a couple of other inflammatory arthritis conditions associated with the seronegative spondyloarthropathies. As I mentioned, I will separate psoriatic arthritis into its own discussion. Lastly, I would like to talk about enteropathic arthritis before we end our discussion today. As I mentioned, psoriatic arthritis will be presented as a different talk later. So inflammatory bowel diseases have been associated with arthritis, and they actually fit into the classification of the seronegative spondyloarthropathies. When we did talk about the pathogenesis or how the seronegative spondyloarthropathies occur, it makes sense that Immunopathologic arthritis might be associated because there's inflammation of the gut, and as we talked about how that could lead to possibly absorption of factors that can set off the arthritis. Inflammatory bowel disease such as ulcerative colitis or Crohn's disease has been associated, and I'll talk about that a little bit in a minute. Bowel bypass arthritis, back in the 1970s, it was noted that patients that had a bowel bypass where there was a large section of blind loop of colon of small bowel left, that they could sometimes get a rash and arthritis associated, and some of these patients had to have the bypass taken down. And then Whipple's disease, which is another type of gut disorder associated with a bacterial infection, has been associated with arthritis. Now this is just showing the incidence of arthritis with colitis. Ankylosing spondylitis can occur in up to 15% of patients with ulcerative colitis or Crohn's disease. And then with respect to peripheral arthritis, up to 20% of patients with Crohn's disease or 10% of patients with ulcerative colitis can have an associated arthritis. This is a colon that has been resected in a patient with inflammatory bowel disease, and one would suspect that this patient has Crohn's disease as their skip lesions, and in other words, you see normal gut, then you'll see an area that's been scarred down, the normal gut, and then an area that's scarred down, which is classically described in Crohn's disease. This is a slide just helping us to remember this patient obviously has had part of his colon removed and has ostomy, which is what you're seeing with this circle here and here. In this picture you can see that he has sacroiliitis. There's blurring of this joint and loss of this joint, and there's also some blurring of that joint, and there's significant hip involvement. There's a lot of loss of joint space at the top of the hip here. So this is the ASAS classification for spondyloarthritis, and this is actually for all spondyloarthritis, be it either axial peripheral. With respect to axial disease, again, if they have greater than 3 months of back pain, an age less than 45, and sacroiliitis on imaging, then we require one of these features listed below, and we've talked about these. Or if they have an HLA-B27, then we require 2 of these features, and we would then classify them as having axial spondyloarthropathy. For patients with peripheral disease, and that again is our patients we just discussed, patients with polyarticular disease, meaning just a few joints, or an enthesitis or a dactylitis, if they have any of these extra-articular features, or an HLA-B27, or X-ray changes, then one would classify them as having a peripheral spondyloarthropathy. So this is sort of a nice summary of our discussion today, how these are classified. As I mentioned, I separated psoriatic arthritis into a separate talk because it has lots of different ways to present, and I spent a little bit of time discussing treatment. As always, I would encourage you to go back and review the introduction slide to help you understand how I'm putting these together, and I would also encourage you to review the rheumatoid arthritis treatment discussion to understand some of the medicines that we've used.
Thank you for listening to my discussion of the seronegative spondyloarthropathies. As I mentioned in the discussion will be on psoriatic arthritis in particular. Today we talked about ankylosing spondylitis and reactive arthritis or Reiter syndrome. We talked about what we think causes them, and as we discussed in this lecture, we have a better understanding of what causes these than some of the other arthritis conditions we talked about. We talked about how I diagnose these conditions, and we did talk a little bit about treatment.